Good afternoon, everybody. This is Yusuf. I'm one of the third-year integrated vascular surgeons here at Houston Methodist, joining you for DeBakey CV Live. We were on hiatus for a few months because we had the winter holidays followed by a big freeze in Texas, so we're back to you now. Today's topic is going to be regarding billing and what residents need to know as far as billing and sort of making your way into whether or not you end up in private practice or academia, wherever you may end up in the future, sort of how billing and everything affects you and your residency and how as a resident you should prepare for the future. So we are going to be joined by two special guests today. The first one is Dr. Thomas Lowe, who is actually one of my chiefs when I was an intern, and now works at one of our large periphery hospitals at Houston Methodist Woodlands. So hello, Dr. Lowe, thank you for joining us.
Hey, Yusuf. Good to be here.
And we will also later be joined by Dr. Cheng, who is currently in the OR but is making his way back to the office. Dr. Cheng joined us from UTMB a few years ago and is now at another one of our large periphery hospitals, Houston Methodist Sugar Land. So he's sort of got a more senior perspective on billing and what he expects his residents to know as far as billing is concerned and how we as residents can get prepared for life outside of residency. So just to begin, Dr. Lowe, do you want to sort of introduce yourself, how you came out of residency and where you ended up and how things are going for you?
Sure. So like you said, I was in the training program at Houston Methodist for 7 years. I graduated 2 years ago and then joined the faculty at Houston Methodist and joined primarily up at the Woodlands campus about 40 miles north of the main medical center. We've gotten quite busy up here in that intervening time, and it's been a transition. I had originally planned to come up here kind of regardless of which hospital I was going to be joining or private practice. I had just aimed to be in this area, but it made sense at the time with a brand new facility being built to join on. So that's how I ended up here.
All right, thank you. So before we begin, there are two options for people who are watching to submit questions. The first one is you can go to pollev.com and enter the code DeBakey, that's DEBAKEY, or you can text to 37607, again the word DeBakey, that's DEBAKEY, and that text is 37607, and the website is pollev.com. So the reason we decided to host an episode sort of featured on billing is because, this is all about, this specific episode of DeBakey is about residency and sort of what it means as a resident and how to prepare yourself coming out of residency. I'm personally a third year, but I'm sure there's fourth years and fifth years, especially fifth years, who are starting to look into the job market and figure out where they're going to end up. Some of them may be going into private practice, some of them may be going into academia, some of them may be joining large established groups, and some may be heading out there to hang up their own shingle. One thing I've heard over and over again is that you hear grumblings in the OR about this is where billing is headed, this is how billing is changes, and I've gotten many times notes from the billers and from the coders saying like, you need to fix this in your op note, you need to change that in your op note because that doesn't accurately describe what was done in the operating room. And I've noticed that in residency we get didactics about anatomy, we get didactics about how to operate, what to do, clinical decision making, but you never really get to a point where you talk about what happens when you leave residency and how to be prepared for what you're going to need to know. And especially for someone who's joining a private practice or someone who's heading out to hang up their own shingle, as a third-year resident, I'm not even entirely sure where to look to get started with that kind of stuff. So you headed up to Woodlands on your own, which is very respectable. I mean, you had the support of the faculty downtown and the other periphery hospitals, but how did you get started figuring these things out for yourself, Dr. Lowe?
So the short answer is, of course, it started well before I got up here. That was a big part of my peripheral rotations in training when I was out in San Jacinto in particular. That was where it really started to click that this was an important part of what I was going to be doing. And one of the things I would disagree with your assertion is this being particularly important for private practice or joining a practice. I think it's important it doesn't matter what job you're joining. This is the lifeblood of how your practice is going to function, whether it's academic, hybrid, or private, or somewhere in between. It's going to be an ever-present part of how decisions are made in the hospital. And a lot of times when things don't make sense to clinicians, there's pieces of the puzzle that are missing. And a lot of the times that has to do with how hospitals function, how practices function. And if you're missing those pieces, you're not going to be able to be as effective as a clinician. And while you really want to insulate yourself from that to a certain extent to deliver the highest quality care for your patients as possible, it's a practical reality of the job aspect of this. And so I got started early. There was a particular PA out in San Jacinto, or now Baytown Hospital, who really would harp on me about exactly what you're talking about you need to change things, you need to get your billing and coding up to snuff, and there was a very good reason for it. And she explained to me a lot of the reasons behind it, and also really emphasizing why it was important. And that really changed my perspectives, and it made me much more focused on not necessarily the billing aspect, but the coding aspect of it. And everything that you do gets knocked down to just 5 numbers, right? Everything you do gets knocked down to a CPT code, and then obviously your ICD-10s for the diagnoses. And so when you have to distill down complicated things you do in an operating room to 5 numbers, it really sobers you that there's going to be a communication gap between what you do and what the hospital sees, as well as what the payers will see. And so understanding that is vitally important. And I really focused on that in my last probably year and a half in training, in terms of, okay, if I go into practice, how do I do this on my own? How does this look? And when I was thinking about being a solo practitioner, it was really okay, how do the finances of this practice work? How do these different things reimburse? How does the payer mix affect this? And all those things. And that was the process. Like you said, there isn't a good way to look this up. There aren't good resources online. There are some classes, some things like that, but really you're kind of piecing it together yourself. And so from my perspective, you can't start early enough in terms of figuring this type of stuff out.
So before we dive into details a bit, I guess to contextualize this conversation, how much of an impact does that really make when you're whether you're on your own or you're part of a large group? Is it quantifiable, or at least from a qualitative perspective? Can you talk a little bit about how much being prepared has made an impact?
I think it's made a night and day difference in terms of how much I have to figure out on the back end. So I'll hear other physicians sometimes talking about, especially those that came out of training or 1 or 2 years in, about the queries that we get from our billing and coding staff. And I think I've had 4 or 5 of those in the last year and a half. And I think I credit most of that to, again, that early education and preparation for really having an appreciation that this is important and focusing on it, because when you focus on it, it comes pretty quickly. And so it's made a daily impact, because fixing things on the back end, especially a week later, a month later, is so much more challenging than just doing it right the first time around. And it keeps you out of trouble. And of course, I'm only 18 months in, so maybe that's going to come up later down the line in terms of the billing. But no, it makes a big difference. And now how it impacts you, whether you're in private practice or joining a group or joining a hospital system, at the end of the day, this is how you generate revenue for whatever entity you work for. And so it's going to be a relevant factor. Again, does it impact me day to day? No, not at all. I don't look at the statements. I don't look at it, but from a month to month or a quarterly basis, it's something that you have to pay attention to, because you have an impact on your practice. You have an impact on the hospital at large, other practitioners. And again, understanding the dynamics, whether it be why different consultants are going to take consults or not, or move quickly on things or not, are sometimes predicated on these types of things. So even if it's not impacting my practice directly, it's understanding why people are making the decisions they're making around you that is really, really important for being efficient.
So I guess you mentioned that your third year rotation in San Jacinto was sort of where you started picking up on these things. I mean, I'd have to agree with you. I'm out in San Jacinto right now, and that same PA has been excellent as far as giving me tips and feedback as far as how I should write my H&Ps, how I should write my physical exam, what I need to include in my op note, what doesn't need to be in my op note. How did you start diving into this? So you mentioned that once you got introduced to this, it sort of became something that you kept up as far as your attention on over the next 2 years of residency. Tell me a little bit about what you did there.
For sure. No, I think there's two main things. The first thing is the E&M coding, which is a whole kind of beast in and of itself. It's gotten a lot simpler actually in 2021 with a slight rule change. And then there's the op note and procedure note portion of it. As far as the op notes and procedures, it's just like how as an intern, a second year, you start to learn how to dictate or you learn how to write operative reports. It's an additional layer on top of that. And it was every time someone would give you feedback or you go out and seek feedback on how to write or craft an op note that, number one, makes sense so that when you come back to it a year later, 3 years later, 10 years later, you understand what you did that in the operating room. At the same time, you also want it to be relevant for the people that are translating that into those 5-digit codes, or for yourself to be able to translate that into 5-digit codes so that it can be billed appropriately, so it's not under or over coded. And so to me, it was really every single, to be honest, it's a little bit of trying to do the work ahead of time to be efficient later. And so, there's only so many different operations you do and so many different variations. So it's really building into the operative templates that I use a lot of those billing and coding things, even if it's putting the actual CPT codes in there. What I do is I overload my templates with these things and then I delete the things that are not relevant. But that's much more efficient than typing things in. And then also adding the lines about different things that are relevant. For instance, use of ultrasound or use of IVUS or use of different other modalities in the operating room will modulate different codes. And so you want to have those in the templates, and you learn them as you go along, but you only learn them if you're paying attention to them and you're getting feedback. If you don't get feedback on them, you won't learn unless you're going after it yourself and looking it up and reviewing. Most companies that have devices will have little advice things, little pamphlets for how to code their devices, and they're usually pretty robust and a little overkill in terms of their explanation, but that's perfect for someone that's learning how to put these together to really go for it. The E&M coding itself is pure practice and having someone review them. I used to bug our one of our lead coders when I was in training, actually. And if there was a complicated op note or a complicated H&P or something like that, I would actually just say, hey, can you eyeball this and let me know? I think this is a level 4 or level 5, or I thought this was this type of CPT code, and ask for her feedback on it. Or I'd ask for her to give me what was the actual readout for this operation and map it against what I thought it was going to be.
Yeah, I mentioned to you before that I do use quite a few of your op note templates just because they're set up so well. And I think the attendings appreciate it too because they see how it's laid out. So, for example, one thing that comes up, we do a lot of leg angio. So first order selective catheterization of the external iliac artery, second order selective catheterization of the superficial femoral or the popliteal artery, third order of a tibial, et cetera, et cetera, et cetera. When you were building those templates, what resources did you set out to do? And I know from my perspective, when I do op notes in that way where I actually include all the CPT codes and I include the exact procedures, it makes it quite a bit easier for me to even do my own case logs, because when I do my case logs, it expects me to have the CPTs and everything in there. And so, for example, whenever I do leg angios now, I can just load up my op note and just type in the CPTs whenever I'm doing my case logs, and they show up on time. And this is speaking as someone who was 200, actually over 12 months behind on case logs and managed to catch up in a week after I sort of figured out that CPT system. So, every time I've tried to Google CPT codes online, it's an absolute disaster, right? Like there's, a few companies have like things here and there where they're like, okay, here's a list of vascular procedures, but then you'll see there's a list of vascular procedures from 1998, and here's the CPT codes, and then a list of vascular procedures from 2012, and here's their CPT codes, and then here's 2020 Part A, and then 2020 Part B. How do you reconcile all that? I mean, it seems like, especially during residency, that's just a lot to have to put up with, especially when everything else is going on.
No, for sure. I mean, you're never going to get the full kind of understanding and appreciation and I guess knowledge base that you need to in order to do this. And that's not the role of being in residency, right? I mean, to me, it's laying that framework and also that mindset, I think, is the most important thing. And it is difficult to reconcile because there aren't great resources. Now, of course, there is the master code book. If you look at any of the coders on their desk, there's a gigantic, ringed notebook that has every CPT code that would possibly matter to a clinician, but at the same time, there's a lot of diagrams in it, pictures of it. And the only way that I started to really figure out the lower extremity angio stuff was to really sit down with someone and go, how do you even start? And that was Beth Ann Daly, one of our coders, that sat down and explained it to me and basically read through a couple of op notes with me and just went through why she couldn't code certain things or why certain things got actually billed appropriately. And it really comes down to, I started with Boston Scientific had this great graphic that had all the things, but in graphical form. So it had the CPT codes alongside the different vessels, and there wasn't really any explanation on there, but it was a neat, easy guide. I really liked one of the other companies' EVAR templates that had all the CPT codes on there. And, it takes an afternoon to really learn and understand endographs, for instance. You just have to sit down, read a couple of sources and read the explanations and then check yourself, right? Yeah. Bill out an EVAR that you do with one of the faculty and then sit down with one of the coders and go, was this right? And, it's labor intensive, but you get the swing of it. And again, this is my argument is, you don't want to overload yourself with this. That's not the purpose of being in residency, right? You don't need to know the nuances of it, but you want to be in the mindset that this stuff does matter. You don't want to be blind to it, and you don't want to be blindsided by it, because once you get into practice and it keeps going, people come out of the woodwork and say, hey, this is not appropriate, but this is important to us, either as a practice or from a hospital standpoint. And then also affecting your bottom line if you're in private practice. You can definitely have a huge impact.
Thank you. So Dr. Cheng, I believe, has been able to join us. Again, to reintroduce Dr. Cheng, he's one of our attendings at one of our other large periphery hospitals out in Sugar Land. Dr. Cheng was previously at UTMB before he came over to us a few years ago. Dr. Cheng is one of our more senior faculty members and another one of the attendings whose op notes and whose templates from Epic I use quite frequently. So thank you, Dr. Cheng, for joining us. Can you hear us?
Sure, thanks for having me. Yes, now I can hear you.
So I'll start with that same question that I started with Dr. Lowe was, when did you as a resident, or I guess even if it wasn't as a resident, when did you start thinking about this stuff, and when did you start actively building it into your practice?
Okay, so after fellowship, I worked at UTMB in Galveston, and at that time, we had coders, and I didn't have to learn how to code. But then after a couple of years, we had a change in administration, and it was kind of forced upon us to learn coding. And I didn't have any formal training beforehand, and then when they want us to start coding, I didn't have any formal training at all either. It was just coders, they'll come to your office, meet with you for half an hour, and just say, hey, this is what you do. Lower extremity, you do this. Upper extremities, you do that. And so I was just kind of learning it on my own. And then I started coding with the coders, kind of looking at your coding to make sure it's correct. And then after that, it's just kind of get updates every year. So I had to learn it on my own without any formal training, and it really helps so that what you describe in the up note may not make sense to coders, but when you code for yourself, you make sure you're capturing all the procedures and make sure you're getting all the reimbursements. So yeah, I think it's when you're in training right now, I think it's a good time to start learning all the coding.
So another question that I asked Dr. Lowe earlier was, in the various practice types that you've been in, how much have you noticed that that's made an impact, or how important do you feel that is as far as, again, revenue, or just qualitatively speaking, does that make a big impact on your career and sort of what you're able to accomplish within your career?
Yeah, it does. The impact on your practices, I think you definitely, after comparing before and after learning how to code, your coding is more accurate when you do it on your own, and just doing the same procedure without changing your practice, my revenue went up just because you're coding correctly. And so
and by doing it on your own, you mean including the CPTs within the OpNo as opposed to letting the billers or coders try to figure it out on their own, or is there something more than that?
Right. So when I said without changing any practice, revenue went up. Before, I would just dictate my OpNote, and the coder would read the OpNote and code what they think they understand. And then when I started coding on my own, I would list every procedure, everything I did, and without changing my practice, coding on your own, my revenue went up.
But just to clarify, Yusuf, so putting the CPT codes in your OpNote is not enough, right? So the billers and coders will still go through your OpNote, and they'll see to make sure that you can justify that CPT code, and then they may query you, which is why it's nice to put those in there as a guide for what you're thinking. But at the end of the day, what Dr. Cheng is also talking about is we actually can submit our codes ourselves in Epic itself, and so it kind of bypasses. You still have someone, especially in a big organization, that's double checking a lot of things. But you actually have you can have a lot more direct control over that if you want, and to actually do it yourself. And then obviously if you're in private practice, if you don't have a billing group behind you doing that, you're doing it all on your own that way.
Got it. Okay. So a question I had, so Dr. Lowe does not currently have residents. However, hopefully in the future he will start taking residents. But Dr. Cheng, we do rotate with Dr. Cheng in our third year of practice, or third year of residency. So Dr. Cheng, what are your expectations as an attending as far as like what your residents should be? So when I was rotating on your service, I made sure to delete the CPT codes that didn't apply to the procedure that we did, or add on. If we did something special that wasn't included, I would add in the CPT codes. What are your expectations for residents, and sort of what is your approach to teaching residents how to bill appropriately and how to sort of get into the groove of doing this on a regular basis?
Yeah, I think third year PGY3 is a good time to start coding. I mean, first 2 years you're just trying to learn the procedures and steps and all the different catheters. I think third years, once you understand some of the procedural background, I think it's time to learn coding. So I would say starting third year, I would diagnostics, and then as you are familiar with the diagnostic coding, just such as first order, second order, third order catheterization. Once you're familiar with that, then move on into more specialized procedure like atherectomy, and now with the new procedures such as shockwave angioplasty. Those once you have the basics, then adding those specialized procedure on top of your basic knowledge makes it a lot easier. So as a third year, I would say it's a good time to start learning at least the diagnostic portion of the coding.
Got it. So we're 30 minutes in now. We have 2 questions currently loaded. The first question is there a good, concise resource or document for vascular surgery coding and or H&P console op note tips and tricks? So I personally, I will, at least for people who are at this institution or whatever institution you're at, go through your, my recommendation would be at least go through your attending's op note or H&P and progress note and clinic note templates, because a lot of those have those things built in there. And then getting feedback and talking to the attendings, like, does this CPT code apply to what we did? That worked very well for me. But Dr. Cheng and Dr. Lowe, are there any good, concise resources or documents for this stuff?
I don't think so. I think for E&M coding, I use E&M University was kind of how I learned, and that's pretty concise in terms of here's templates, here's an explanation for why this code's at a level 3 visit, a level 4 visit, etc. To me, just having a basic form, a basic table on my desk to basically map out the visits as they came in really helped. But there isn't a great, I think, analogous thing for op notes and CPT codes in the OR. Like I said, some of the companies have little explanatory things. We did a new procedure here this week that I'd never done before. And the first question to the rep was, do you guys have any guidance on how you bill for these codes? Because I've never billed one of these before. And they had a pamphlet, right? They want it to be easy. They want you to do more of their cases. And so they had a 3-page explanation for how you bill for it and even how you submit it to the insurance companies and all the stuff that is obviously I'm not going to be doing, but I can hand off to my staff and say, hey, this is their guidance on it, and these are the codes that I'm expecting for this operation.
Got it. Dr. Cheng, any suggestions?
Yeah, in terms of resource, when you work like us in a big institution, there are coders, and I found them to be very useful. You call them, you email them, and they're usually right at your office or wherever you want to be within 24 hours. And so I think if you have resources like that, use them often. And in terms of basic foundation and some reading, I find that there's really no concise resource, or at least I haven't found one. I use the CPT code that they pretty much publish almost every year, and just focus on on vascular surgery. And I think just reading through that once will help you understand why there's a first order catheterization, second order, third order, selective, and once you know that, then everything else kind of makes sense. And then CPT codes, they get updated every year. I find that another helpful resource is use your specialty organization, vascular surgery, general surgery. They also offer coding courses every year, and so that's another resource that people can look into.
So one thing I did mention earlier is when I was rotating in Sugarland and I was using your op notes, Dr. Cheng, with all the CPT codes loaded in there, it actually made it a lot easier for me to do my own case logs, because when I'm filling out my case logs, I'm expected to do the same thing where I put in all the CPT codes for the procedure, and that helps categorize what I've done and sort of what level of experience I've accomplished and what more I need to do. So making that a routine part of all of my op notes has actually made a big difference for me, because it makes it a lot less of a hassle to do my own case logs. There is one additional question. If you are in private practice, can you hire a coder? And if so, should you? Or is it better to learn on your own?
So I've never been in private practice, but I would think that it's from what I've heard talking to people in private practice, it's worthwhile to hire somebody who only specializes in coding, because number one, you probably don't have time to keep up with all the updates, the new bundling every year, and number two, I think it's good to have somebody double checking your coding. So I think the amount of money that you get from proper coding easily pays for a coder. So from what I've heard, yeah, it's worthwhile to hire a coder in your private practice.
And Dr. Lowe, I know you investigated possibly going into private practice on your own when you were finishing up with your residency. So would you have started out with hiring a coder, or would you have tried to do it on your own at first and then expanded from there?
No. I mean, when we were putting together what the practice would look like and the budgeting things out, that was a very clearly going to be a part of things from the beginning. That investing in that, like Dr. Cheng said, I mean, investing in that up front pays for itself, and putting in good habits early is really, really important. So that was going to be a part of it from the get-go. There are a lot of different services out there. You can hire someone directly that would work for your practice, or there are contract companies that will do things remotely that you just kind of send everything to. There's a couple of different models that we had investigated looking into. It's painful though, compared to working for a large organization where that's largely provided and you don't have to think about it. There's just kind of a small group of people or small army, depending on how big your institution is, that are available to help you, number one, do it on the back end, but also help guide you is really important. And I can't echo that enough. Like Dr. Cheng said, I mean, it was invaluable to be able to sit down with a coder and actually go through what their logic was or what their understanding of how these things are built out. And then I would layer onto that my understanding from attending the SVS coding course and things like that, and we'd figure it out together at some point.
Yeah. So I know in my experience, one of the things that I typically get queries about is incision and debridement. Is it sharp excisional? Is it skins? Is it soft tissue? Is it muscle? Is it fascia? Is it, and what size was it? What was the total surface area? Specific mistakes that you found yourself making frequently, or are there like specific pet peeves regarding coding that either of you might want to talk about?
Yeah, I think in terms of wound debridement, I think it's important to, I know sometimes we forget, but we forget to measure the size of the wound, because once you have the size of the wound, you can calculate the area, and that will really help you code correctly. Such as initial, I believe 20 centimeter square, and then each additional. Before, I used to think if you're over the initial limit, all you have to do is just do one additional. But what I found out later is, if you say that you have 50 square centimeter, so the initial 20, and then you have 30 left, so you can do each additional 3 more times. I used to just do it 1 time, but you can actually do it 3 times. So so that's one, I think, things I see happen all the time. And then in terms of sharp incisional, that also helps with the correct billing, give you the reimbursement that you deserve.
Yeah, no, wound care is a big one for me as well. Starting up a fairly robust wound care practice in this area, it's exactly that. It's really documenting the size. I really try and take pictures of things with a ruler in there, and documenting the size, and even just writing it down on a towel and then taking a quick picture of it so I have it for my dictation later. And the depth, what tissue is being sharply debrided, it all goes into that. And it's an algorithm. Once you understand it, it's very straightforward, but it is very relevant, because your reimbursement for that is widely variable depending on how many of those codes you put in. And if you do a large debridement for, let's say, necrotizing fasciitis, and it's several hundred square centimeters, yeah, you can submit quite a few codes for that, and it may take an appeal or something to get that through with a lot of the insurances. But if you code it effectively, you're giving your billers the best chance possible to get what the effective work that you put into that case. To me, probably the most challenging is lower extremity angios. I didn't practice it enough, or I didn't pay attention close enough while I was in training. So I really did build that one kind of from the ground up once I got into practice. Certainly more so than the dialysis things and things like that. But yeah, that was probably the most challenging for me, was to get the lower extremity angios down.
So I think one misconception that I've had in the past that has since been corrected, and I know other residents have shared this misconception in the past, is that coding and billing stuff doesn't really matter when it comes to H&Ps and progress notes and discharge summaries. The bulk of what you're going to be doing is with op notes. So how true is that, and how much does coding and making sure you document the right things as far as HPI and physical exam are concerned, how much of that does that make a difference overall as a vascular surgeon?
Yeah, over a quarter of my billing is E&M coding. I see I do a lot of medicine in addition to what I do, so maybe that's a little overrepresentative. But with the direction that medicine is going with the 2021 updates, that's probably going to be a slightly larger share. But
what do you mean by
a quarter or more. I'm sorry?
What do you mean by that with the 2021 update?
No, there are small adjustments every year.
Okay.
So the percentage, I think some of them went up by even 50% of what you got in clinic for a given H&P, whereas I think the overall revenue for vascular surgery operations decreased by about 7%. For 2020 versus 2021, and so that's a small adjustment that you really shouldn't pay attention to, because that's really out of your control. But no, it's vitally important, the E&M coding, and that's one of the things that you realize how much is missing out when you're in training, because if if your E&M coding isn't up to snuff, it's not going to get billed out appropriately. If it's not cosigned effective and appropriately, it's not going to be billed out appropriately, and that's a significant revenue. It's not the lion's share of what we do as vascular surgeons, but it's certainly a significant portion of it.
So for those of us, including myself, who don't know, what does E&M stand for?
Evaluation and management. So okay. It's your clinic progress notes, H&Ps, consult notes in the hospital, ER consults, things like that. Again, all get distilled down to 5-digit CPT codes, and they're all on a scale. To make it basic, there's the maximum levels, level 5. You can measure that by time that you spend with the patient and managing things, or it can be based on what you actually do. So the studies that you read, the records that you review, physicians that you talk to, and then whether or not you take someone to surgery, or what the actual management is, all coalesce down to that 5-digit number that denotes how much effort you put into taking care of that patient in terms of evaluation and management.
Got it. So Dr. Cheng, you've had a number of us residents rotate with you. What frequent mistakes do you see in our H&Ps and our clinic notes that you feel as residents we should be more aware of?
Yusuf, going back to how important H&P proper documentation for clinic notes, another thing you want to know is not only for revenue, but you got to remember, Medicare, they will audit. And you would think that over coding, trying to get as much reimbursement is bad, but under coding is just as bad. So you want to make sure you have proper coding in case you get audited. And then another thing is with now a lot of clinic visits are going into virtual visits. I know a lot of insurance company are doing more auditing to make sure that the virtual visit actually took place, instead of you just submitting a virtual and when actually nothing was done. So yeah, proper coding for clinic visits and H&P has a lot of repercussions if you don't do it correctly. And then going back to mistakes, the clinic visit H&P, a lot of the coding is based on how much you do, how many systems. So that's why if you remember my clinic notes, H&P has a template as well, so that at least we so that we don't miss any system. And because if you want to build for a certain level, you need to have a certain number of systems that you go through. So as a resident, I think it's important to kind of to learn how many review systems you need to do and how involved the decision making is. I think that's the hardest part, and I think it's easy to make a mistake. And I have to admit, I mean, I still make mistakes because I thought that something that was pretty easy, and I would code for a lower level when coder would tell me, oh, it's actually it's a chronic disease, it's a more complex higher level, and vice versa. I thought it was a pretty involved decision making, but when coder would come back and say you can't code that high. So it's a mistake that I still make.
So actually I just had a question texted to me, which is, how much of that stuff matters when you're doing global visits, and what exactly is a global visit? Dr. Lowe? Sorry, we can't hear you. I think you might still be muted.
Sorry, took a phone call. No, so global periods are the period that you are responsible for taking care of the patient for the operation that you did. So the smaller the operation, the shorter that global period is in general. But there's a whole big table for every procedure that we do. And so everything that is associated with that diagnosis that you took the patient to the operating room for is encapsulated under that. So if you did, let's say, an open aneurysm case, you're going to see that patient in the clinic afterwards. That is covered underneath the CPT code that takes you to the operating room. It's all bundled together. And so you can't bill for additional E&M coding unless there's a new diagnosis, right? So someone that comes into your clinic, you take them for an open aneurysm, then they come back, and now just making up, they need some fistula work because they're end-stage renal. Well, maybe they're fistula thrombosed and you need to take them. That's a different code, and you can actually get E&M coding for that. But you can't get more coding for the operation that you've already done. So that's what the global period is for.
Okay.
But like I said, it's a complicated big table.
So I guess, let's say we do a big operation for a patient who's in the hospital, and then we're rounding on them. Like, does your progress note still need to include all of those review systems? Does it still need to include physical exam incorporating every single thing outside of what your specific procedure required?
So no, it doesn't. So there's two purposes in my mind of hospital documentation. Number one is communicating with other physicians and nursing, and then the other purpose is billing and coding. And so to me, I have one basic template that makes sure that I document appropriately for my billing and coding, and then it guides me more or less for that. And so if it's someone that I'm managing in the hospital and then I will eventually operate on, or there's something that someone I'm never going to operate on, but I'm doing E&M coding on, I have that template. But you'll see most of my post-op, if I've done a carotid endarterectomy and I round on them the next day, it's just the bare minimum of what is necessary to communicate to the other hospital staff what my thinking is on that patient. And no, I don't include a robust review of systems. I include the relevant things in terms of my subjective, my physical exam, and then what my assessment and plan. And you'll see my assessment and plan is probably 2 to 3 times the size of the rest of the note, because that's the relevant part to the vast majority of people reading my notes.
Yeah. Any input on that, Dr. Cheng?
Nothing. I agree.
Okay. Do we have any more questions from the outside, guys? All right. So thank you, Dr. Lowe and Dr. Cheng. I guess one question, a personal sin of mine, is writing 12-point review of systems is completed and is negative except for as stated in the HPI. Is that okay?
I actually don't know the answer to that. I've heard varying opinions on it. I don't think it's particularly helpful to say that, right? Because you're always going to have some positive there that you're going to miss, and I think it's inaccurate coding. To me, actually going through the list, there are efficient ways of filling that out, especially in the clinic, without resorting to a one-liner. But I actually don't know the answer to that, and I've gotten conflicting reports from different billers and coders.
Do you know, Dr. Cheng?
I'm not sure, but because I use the template, so
Yeah.
I list everything out, just so that I don't have any problems later. If you come back for auditing, I think correct documentation first place is important. And so, but I do know that sometimes if let's say it was a pretty easy clinic visit, not during the global period, for something like leg swell, something that's not very involved, but so your review system is not going to be complex, and your decision making is not going to be very complex, but you spend an hour talking to patients, answering questions, you can actually document at the end, I spent however amount of time discussing patient about care, so you can actually get higher coding than the decision making that you did. So you can actually put in the amount of time at the end of your note to get a higher reimbursement.
Got it. All right, so one last question. What do you think is the most missed or overlooked CPT code or billing action in vascular surgery?
One that I was not aware of until I started in practice was there's a difference between central veins and peripheral veins in terms of fistulograms. There is a separate code for that. So if you do an angioplasty in, let's say, a cephalic arch lesion and then a subclavian vein, that's a separate code. So there's a fistulogram angioplasty code, and then there's also the central vein code. So documenting that appropriately, that it is a different vein, is really important. Is probably the one that I missed, at least initially, and is pretty relevant because it's often that there are multiple lesions. But that's probably the biggest one for me.
Dr. Cheng, for you?
Sometimes, if I'm not sure about coding, I would list out the procedures clearly. For example, if I say, let's say you're doing trauma, and I did embolization of internal iliac, both right and left, and then I went up to the liver and did core embolization. And sometimes, if I'm not sure, is this additional second or third order? How many times do I need to list it? Then I would say, second order catheterization of, hepatic artery, third order catheterization of internal iliac. If I'm not sure, and then I would just kind of list everything out. Mm-hmm. And the reason I do that is because Houston, we have the privilege of coders that will help us code. So if I'm not sure, then I would just list everything out as clearly as possible.
Got it. Well, thank both of you for your time out of your busy day to join us and help us talk about this topic. I mean, it's an enlightening conversation for me, and I feel like this really sort of sets me up to know what I need to be focusing on. And again, I do thank both of you personally for letting me, or I guess you didn't let me, but I just took your op notes and H&P templates from Epic Smart Phrase Manager. So I do appreciate that. Any closing comments, Dr. Cheng? All right.
Good luck.
Thank you. Good luck.
All right.
It's a challenge.
All right. Y'all take care. Have a good day. And thank you everyone who chimed in to view our DeBakey CV Live. We'll be back on in about a month with our next topic that will be announced soon. So thank you very much.